A lot. I appreciate you guys including me in the schedule, Julio and others. Since I have a very brief time, I thought what I would concentrate just on three main things that I think are important, outstanding questions. First is the effect of ART on HIV infectivity in MSM, the issue of behavioral disinhibition, and then public health program implications and operational research. So clearly the biological plausibility that antiretrovirals decrease transmission among MSM is high, but we actually don't have the kinds of evidence that we have for heterosexual transmission in terms of discordant couple studies. HBTN 052 did make some effort to enroll MSM, and that was not successful. So instead what we have is much more limited. There is some phylogenetic analysis suggesting that ARTs decrease transmission in a study that was undertaken in the United Kingdom and did have very large effect size with a rate ratio of 0.14. Beyond that, what we have is really ecological data, which is inconsistent. So data from San Francisco, as we saw earlier, shows that the number of new infections declined concurrently with an increase in antiretroviral therapy use. But that really hasn't been replicatable in other places. It isn't seen here in Vancouver. We haven't seen it in Seattle. It hasn't been seen in Australia. So not really a consistent finding in that regard. Cohort data from Australia did not observe that there was a decreased estimated transmission probability associated with receptive anal intercourse among MSM over a period of approximately a decade. And you would have thought that there might have been such a decrement had widespread antiretroviral therapy use been effective. So what could we do to get a better handle on this? Well, could we really even do discordant couple studies? I don't know that they could be recruited. Where would they be recruited? Moreover, is there equipoise? Who among us would be interested in enrolling their own patients or couples in such a study? I think most of us would be reluctant. I would be reluctant. We could do partner notification studies. I think these are feasible. You could potentially attempt to identify transmitting pairs through phylogenetic analyses with retrospective ascertainment of viral loads. Whether those would be definitive or not is a little harder to say. Additional phylogenetic studies probably are doable. Whether rectal shedding studies, there haven't been very many done in recent years, would be helpful. Hard to know. Would that be really definitive? Would it convince you? Now, in terms of behavioral disinhibition, there really isn't a consistent association in cross-sectional studies between high-risk sexual behavior and being on antiretrovirals. In fact, more often than not, the opposite association is observed, where people who are off ART engage in greater risk. However, if you look at HIV positives, unprotected anal intercourse is associated with the belief that antiretrovirals prevent HIV transmission. And in HIV negative men who have sex with men, at least one cohort study has demonstrated increase in high-risk sexual behavior concurrent with the adoption of HIV treatment Optimism. So what could we do there? Well, I think additional cohort study data would be useful, in particular measuring the extent to which increases in Optimism are associated with changes toward greater levels of risk. Ideally, we would be doing these in both HIV positive and HIV negative men who have sex with them because the Optimism potentially affects both populations. And then I guess the question is, do we want to dampen this Optimism? I mean, how do we strike the right balance between promoting antiretroviral therapy use and trying to encourage people to use antiretrovirals to decrease transmission without necessarily imparting to them the idea that this is a panacea. Now, these data come from Seattle. We have about 7,000 people living with HIV in the area. And I show you this to sort of give you a sense of how we're trying to handle it as a public health perspective. We don't have laboratory surveillance data on about 28% of people in the jurisdiction, and that's very common. San Francisco, I think, is 23%. New York and DC actually are closer to 50%. So of the people we have laboratory data on, and I guess the other point I'd make with this, if you look at the people we don't have laboratory data on, it's a heterogeneous group. It includes people, a small number of people who have died, people who have left the area, people who are disengaged from care, and people where our surveillance system isn't capturing it. And if you look at the distribution on how long was it since the last time we had information on you, 43% of people, it's been 5 years or more. So an awful lot of them have left the area. So in terms of the people we do have data on, 65% are undetectable. And among those who have a detectable viral load, only 38% are greater than 500. In other words, a very small proportion of the total people living with HIV appear to be off antiretroviral therapy without a very clear clinical indication for treatment. So I think what we really need to do is treat people according to current recommendations. And our approach that we've evolved is to link this to surveillance. So surveillance-based prevention and medical quality assurance. And what we want to do is, how is it that we evolved that we didn't consistently use the surveillance data for this purpose? We know who the people are who are out of care. So why don't we take those data and use them to identify the people, go find them, link them to care, retrieve them into care, and promote antiretroviral therapy use. We do have some challenges with this. How are we going to improve our surveillance system? How will we define the denominator, the people who are living in the area, and deal with the migration problem? And then can surveillance-based interventions increase engagement in care and ART use and improve clinical outcomes and decrease transmission? I think that this is amenable to randomization, at least in terms of the temporal order in which people receive the intervention. So it could be rigorously studied, which is what our goal is. So that concludes what I have to say.